I'll take it up from there. The president of the International Epidemiology Association, Professor Chandra Padley, the regional counselor for Africa, Ahmad Kwesechu, past regional councillors, officials of the International Epidemiology Association and of the African Epidemiology Association, our respected panelists, the moderator, the leaders of thought in epidemiology in Africa, colleagues within the IEA, ladies and gentlemen. I'm delighted to welcome you to today's webinar, which is coming amidst one of the most trying periods globally. The COVID-19 pandemic has greatly affected and impacted individuals, families, and society at large. However, amidst this turmoil, mankind has demonstrated the resilience and creativeness of the human spirit. The pandemic has provided society with an opportunity to rethink its approach to health and brought to the fore the importance of the triple bottom line approach to human well-being as enshrined within the Sustainable Development Goals, that is, the linkage of economic development, environmental sustainability, and social inclusion. Members of the African Epidemiological Association, AfEA, which is the African arm of the International Epidemiology Association, have played key roles in understanding and deploying strategies and interventions for controlling the pandemic. Going back memory lane, the AfEA came into being after a proposal by committed members of the IEA from the African region at the World Congress of Epidemiology in Edinburgh in 2010. AfEA was subsequently launched in Tinapa, Calabar, Nigeria, at its first regional scientific meeting in 2012. And since then, the association has grown to a membership strength of 366 across many African nations. And this includes the National Epidemiological Associations, of which the Epidemiological Society of Nigeria, EPICIN, and the Cameroon Society of Epidemiology, CASE, have remained the most visible and vibrant. The objectives of the AfEA follows that of the IEA, that is to facilitate communication among epidemiologists in Africa, improve the quality of epidemiological research, update ethical standards and credentials for epidemiology, and foster the use of epidemiological research in the domains of public health and clinical medicine. The approach of the AfEA to furthering these objectives and improving the use of epidemiology for health and national development is to build the capacity of national epidemiological associations across Africa and scale up engagements and partnerships with organizations with similar focus. In this regard, the AfEA, through the IEA, is in official relations with the World Health Organization as a registered non-state actor. Again, this pandemic highlighted the important role our members play in society through the deployment of epidemiological tools and principles to understand and facilitate the control of epidemics and indeed the current pandemic. Across Africa, our members were in the front line, seeking to understand the distribution and determinants of COVID-19, as well as the associated health-related behaviors, and using the knowledge of these to help in controlling the pandemic. In this regard, some of our members got infected or died because of that, while many were affected by the daily anguish and the emotional burden that comes with being at the front line. Through the work of our members, through their sacrifice, we demonstrated the central role epidemiologists play in ensuring human well-being and preserving mankind. In addition, important lessons which date back to the time of John Snow were once again demonstrated. That is, we can actually break the chain of transmission of disease, even when we do not fully understand the causative agent, or the associated circumstances. What we only need to do is to follow the basic principles of epidemiology. And this approach ushered in the reality of contact and droplet precautions through hand washing or hygiene, limiting of physical interactions, and then the use of face mask. Important best practices and lessons also emerge from many health systems across Africa. For instance, in Oyo State, Nigeria, where I served as a member of the State Task Force on COVID-19 and a consultant to the Emergency Operations Center, the centrality of socioeconomic considerations in planning interventions were accentuated. This emphasized the need for adaptive enforcement as opposed to the fully restrictive enforcement. And this adaptive enforcement, was actually stakeholders led. Also, the intervention plans within the space of planning included provisions which cover potential spreaders, unexposed sick, and at-risk communities, in contrast to focusing solely on the exposed and infected individuals, which was the approach initially. Another issue was the levels of trust. Who do communities trust in COVID-related messaging and what is the ideal media for deploying communication? Why the pandemic showcased our resilience in the face of adversity, it also raised issues about gaps in our learning and in the health system, which should provide us with opportunities for investment. Our erudite panelists will discuss their pandemic experience in relation to these learnings, best practices, challenges, and opportunities for improvement. And we have carefully chosen these panelists. We have my friend, a remarkable female African leader that is pushing boundaries, Flavia, Senkubuge. We have Professor Osibogun, my teacher, a teacher of teachers, a mentor, an extraordinary public health leader. And we have Abdool Karim, one of the finest leading African scientists of note. Let me end by reminding us of the African Epidemiological Association Landmark Maputo Declaration of 2019, which aimed at rethinking, repositioning, and rebranding epidemiology in Africa. The summary of this declaration is that we will mobilize to strengthen epidemiology and public health training, as well as the practice for health, prosperity, and general well-being of all Africans. We further declared that we would review progress on our commitments at all future engagements, and we still remain committed to this declaration. I call on all of you to join hands with us in making sure that we achieve this landmark, the commitments that are put forward by this landmark declaration. I thank you for your attention and once again warmly welcome you to this event. Thank you, and over. Over to you, Maki.
Thank you. Thank you, Councillor. Thank you, Councillor Akin, for the beautiful address and welcoming of our honorable speakers. Now we will be moving on to the next portion of the agenda, which is the welcoming address by the Honorable President of the AfEA, Dr. Professor Chandra. Laura, do you mind please putting the tape on for us? Thank you.
Good afternoon, friends. I'm really honored to join you all at this annual general meeting of African Epidemiological Association and regional meeting of IEA for Africa. Dr. Akin, the President-elect of IEA and outgoing regional councillor, and also Chair of African Epidemiological Association, the incoming regional councillor and the Chair of the association, Dr. Amanda, Dr. Maki, the program coordinator, expert panelists, members of the organizing committee, distinguished participants and friends. Indeed, it's a great pleasure to be with you this afternoon. I'm very thankful to my friend Akin for inviting me to this meeting. He is an excellent orator, excellent host, and organizer par excellence. I recall our last personal meeting and excellent arrangements at Maputo, where we had IEA Executive Council and the regional meeting for Africa in 2019. Perhaps after that, we are meeting through this virtual mode, and because of the pandemic, we could not meet personally. At the outset, I extend a very hearty greeting on behalf of IEA and on my own behalf, and welcome you all to this annual general meeting of Association of Epidemiology for Africa. The presence of IEA in African region has been very strong since its inception. I think this association started in early 70s and is now more than 50 years that we are working together. Our relationship has grown stronger and stronger during all these years. If I recall correctly, the initiative to establish African Epidemiological Association was taken by all of you about 10 years back in the year 2012, and under the leadership of Dr. Kingsley, the then regional councillor of this region, and our past IEA president, Neil Pierce. It's due to your continued effort. Now we have grown in the size and strength and contributing enormously to the region in several ways. The organizing committee has evolved a very good program, including a panel discussion on COVID-19, which is extremely relevant to all of us facing this pandemic. If we look at the global burden of COVID, we find that the Africa had 3 waves of COVID-19 pandemic. But it is also important to note that it was the least affected region. If you look at the global burden by COVID, we find that about 6 million cases were reported from African region, while the developing regions like America and Europe had more than 90 and 80 million cases, respectively. So there is something which we need to learn as epidemiologists for such a nice containment of the pandemic. And I hope that your experience for this containment of this pandemic may be of great learning to all of us. And in the panel discussion, we are looking forward for such clues that how the pandemic was managed in your region. I wish that the scientific deliberations and the outcome of this panel discussion and the meeting as a whole will bring new dimension to epidemiology and public health at large. I'm confident that with your efforts and the dynamic leadership of Akin and Amanda, IEA will get further strength in your region. Wish you a grand success. Thank you very much.
Okay, thank you very much, Chandra. Maki, can you take it up from there? Okay, I think we're having some problem with Maki's internet provider. So we'll just move on. Musa Kahn is a moderator for today's occasion. He is currently with the National Institute of Health and also with, he's an associate professor with the University of AfEA, if I get it correctly. Sorry, pardon me. So Musa Kana, over to you to take over the moderation for today. Thank you.
Good evening, good afternoon, and good morning. It is an immense honor for me to be the moderator. I will go on to introduce the panel of distinguished speakers that will be speaking at this very August occasion, even though it's happening in November. First is Dr. Flavia Senkubuge. She is a professor of public health medicine in the University of Pretoria in South Africa. She's also the president of the Colleges of Medicine of South Africa, CMSA. Her election is historic in so many ways, as she is the first Black woman and only the third woman in CMSA's 65 years history to hold the position. The CMSA is the apex body of medicine in South Africa and one of the most prestigious bodies of medicine on the continent. We welcome you, Ma.
Thank you so much.
Is our teacher and father, Professor Akin Osibogun, who is the vice president of the National Postgraduate Medical College of Nigeria. He is so many things to us, and he's a professor of community health. He previously served as a chief medical director of the Lagos University Teaching Hospital. He is the associate editor of the National Postgraduate Medical Journal and faculty chairman of public health of the National Postgraduate Medical College of Nigeria. Well, welcome, sir.
Good morning, all. Thank you, Dr. Kana. Thank you.
Third, we have Professor Salim Abdool Karim. He's the director of CAPRISA. He's a South African with background in clinical diseases epidemiology. He's widely recognized for his scientific contributions to HIV prevention and treatment. He is he previously served as the adjunct professor of medicine at Cornell University and pro-vice chancellor of research at the University of KwaZulu-Natal. In addition, he served as the chairman of the South African Ministerial Advisory Committee on COVID-19, a member of the African Task Force for Coronavirus, and a member of the Lancet Commission on COVID-19. You are welcome, Professor Karim. Well, I suppose he's yet to join us because I don't see him on the panel list here. Okay, now that the introductions have been made, and in order of the introduction, Flavia, you are going to come on first to make your presentation. So I want to make this announcement that the audience can make notes of any question or comment that you might want to make. Wait until all the speakers are finished, then we will have a time for questions and answers, comments. Thank you. Flavia, please take the floor.
Thank you very much. I just want to find out if you can hear me.
Yes, we can hear you.
So colleagues and distinguished guests, it's always such an honor for me to be invited by colleagues who are so esteemed. I have so many brothers, sisters, fathers, mentors on this meeting, and I won't call them all, but just to recognize you and observe the protocol. I do want to say specifically a warm welcome and just to say how honored I am to the leadership of AfEA and just to really recognize the enormous amount of work that all of you colleagues have done in terms of just not only shaping the discourse, but really ensuring that the African agenda is always at the forefront of everything that we do in the health system with a particular lens of epidemiology. And I also want to recognize the esteemed colleagues that I'm sharing the platform with today. So I was given a topic, and I understand your theme is epidemiology through the COVID-19 lens. And I thought that we should just start off with a step back. And I thought that, I thought many things before preparing my presentation. And I thought that, you know, in these kinds of platforms, it is important for me to rather bring about some of those layers that we may not be comfortable about discussing, but they do need to be discussed, and some of those layers which do need us to ponder. Because, you know, before we talk about a lens through COVID-19, it is important, I believe, to take a step back and pause, because COVID-19 does not exist in isolation. It really exists within a health system. So I've termed my presentation this morning, Decolonizing the Health System for Public and a Global Health Response. And so the first thing, colleagues, that I do want to say, I just want to see if I can advance my slides. So I want to start off with one of my favorite authors, and many of you, you know, may have come up with Ngugi wa Thiong'o's work as well. And he talks about, to understand the world and Africa's place in it, we must first understand ourselves. So before we talk about lensing in epidemiology and a post-COVID-19 agenda, and really looking at the lens of epidemiology through a COVID-19 place, I really my first words are to say that we need to understand Africa's place in the world. But before we do that, we first have to understand ourselves. And before we understand ourselves, it means, therefore, that we have to have a clear articulation, because this is an African platform. And so in essence, we need to first understand ourselves and really what we mean by epidemiology in the African sense. And I do want to boldly say that, borrowing again on Ngugi wa Thiong'o's words, to say Black intellectual tradition has given so much to the rest of the world, but it is often invisible. And it is so true. And I think that we as Africans, when we talk in these particular platforms, it is important to understand that each and every single person who is on this particular platform is a Black intellectual. And I think that our space and our place in terms of our contribution has to be visibilized, because for so long it's been invisible. And that's why we use the words engaging, thinking, and then as if the word that comes off when we talk about lensing and some of the solutions in Africa are not good enough. And so they have been invisibilized. And so it has become so much more important, even as we talk about epidemiology through a COVID-19 lens this whole afternoon, that we must understand the provision and be bold enough to actually say, this is our place as Africans, and this is the intellectual capacity and capability that we are bringing into the discourse when we're talking about COVID-19. Because at the end of the day, colleagues, we are talking about COVID-19 today, but we can never forget the global health issues and the myriad of challenges that still face us. Because the reality in our continent is the fact that even if and while we are enduring our battling of COVID-19, we are still faced with other infectious diseases. We are still faced with issues of governance. We are still faced with issues of disasters and conflict, trade and health, non-communicable disease that talk to each other in parallel. And so whenever we are looking at the lens should always remember and remind each and every single leader who is talking about a COVID-19 lens that Gogo Mahlangu or Gogo Adebei or Gogo Senkubuge, when they come to the hospital, when they come to the clinic, even without COVID-19, they are still following these myriad of challenges, not only only just following them, but also they are facing them. And so they therefore cannot wait for COVID-19 to end. It is so important that that is the first lens that we must understand, and the reality of the health system where we function in Africa. And so I do want to say next that, and therefore, if we are going to understand the broader global health challenges, it is still important, again, if we borrow Ngugi wa Thiong'o's words, not to forget the historical nature, the historical voice, the historical space, the historical narrative of the African health system. Before you can talk about an epidemiological lens, going back to understanding what our narrative is, and in order for us to formulate this voice of our lens, we have to understand our historical context, because that historical context, in fact, is what has ensured or is what we see today, and it is what ensures us to respond to the health challenges of today. Because learning from history is vital in order for us to help to shape and ensure a healthy future for all. And so we have to understand the pre-colonial context. We cannot run away from it. What exactly was going on during that time, and what was Africa's response during that time? We cannot run away in terms of understanding the voice, the practice, and the issues that happened during the colonial time. And right now, while we are during the post-colonial agenda, there is absolutely no ways that we can talk about an epidemiological lens for Africa if we do not examine some of these post-colonial agendas, which of course have been involved, have been influenced by the pre-colonial, the colonial, and certainly the era that we find ourselves now in terms of the post-colonial agenda. I must hasten to say that all these periods, before we talk about lenses, we have to understand that in fact these periods, each and every single one of them, overlaps to what we see today, and also the response when we have a crisis in our health system like COVID-19. And so if you look at, so in our understanding of the various time periods, the pre-colonial, the colonial time, and the post-colonial agenda, things were also happening internationally, the formation of the League of Nations in 1919, and that really started to talk about the issues of internationalization. I say this because it is so important for us as Africans to understand that we don't stand alone, and we are part of a global world, and we are part of the internationalization agenda. And then we have to look at what are some of the responses in the 1930s in terms of the global economic depression. What are some of the relationships that were there? What are some of the evolutionary schemes that are there for instance, issues like international traffic rules, international health regulations, and the new articulation of global health. And again, we're going back to understanding the lens. And so we have to understand what are these transformations that came up during our internationalization agenda? What are these transformations that happened during World War II? What did we mean when what were the promises that were made in 1945 at the UN when we were establishing the WHO? And then what is the history of the 1950s in terms of the lens that was adopted and the focus areas that were adopted? And it is also important to understand what is this vision and what is the confidence that the world thought about when they were discussing a world without disease. And with that articulation of the global agenda, it will be very important for us to reassess, to take a step back before we talk about lenses in terms of what is our vision and what is our confidence when we talk about an Africa without disease. We cannot just simply say that we are only eradicating COVID-19, but we must start talking about Africa without disease. And so as much as the historical perspective is important, if we are going to be talking about a new lens of epidemiology, we have to talk about the new lens of an African health system. And so before we even talk about the new lens of the African health system, in my space where I'm an academic, I have to talk about the present day academy. And so is the present day academy really giving us the graduates who will be bold enough, who will ensure that they drive the African agenda, ensure that there is real, tangible change that is not just tangible, but that is also sustainable. And that filters down to the rural woman in Nigeria, in Uganda, in South Africa, and you name it. We cannot run away from the debates if we are going to be talking about a new lens, if we are going to be talking about epidemiology through a COVID-19 lens. We cannot shy away from issues around transformation. We cannot shy away from the voice and the space of calling it what it is, a decoloniality, and actually articulating clearly what is the Africa we want and what is this epidemiology agenda that we want, because it cannot look like each and every single person's agenda. And so before we even understand what kind of agenda or health agenda or epidemiology agenda we want, we have to know who are we? What is this narrative that we are putting in place? What is our epidemiology? What does it look like? What does it mean? What is the name that we are calling ourselves? Yes, we've called ourselves AfEA, but is there another name that is hidden in that agenda that will enable us in terms of deciding the kind of agenda that we want for Africa and the kind of lens? Because we cannot have a lens unless we know what we want, because there are so many players that are out there, and each and every single one of these players, we cannot run away from the fact that they have a lens, they have an agenda, and they each and every single one of them have a clear understanding of the name that they want to call themselves. And so perhaps in all what I have said, maybe what we really need to do is to say, what is this responsive agenda? How do we respond? We cannot run away from the fact that there will be some disruption, because as I always say in many of the talks that I give, that we have to be sober-minded and say, these structures that we are building upon or on, are they geared enough to ensure that there's a sustainability and that Africans' voice are heard? Because if they aren't, then we have to be disruptive and we have to shake those tables, because you cannot build on a structure and you cannot have a lens on a structure that is not responsive to the narrative and the texturedness of us as Africans. And all in all, as I said before, this particular structure has to be quite impactful as well. And so in my sense, my commitment in our space in academia, we have to have an inclusive academy that has got a very good understanding of what we need when we talk about the lens. And when we talk about the lens, we have to listen to the soul and the heartbeat of Africa. And as philosophical as that sound, and as idealistic as that sound, that heartbeat is in the voices of each and every single community members. It's in our brothers, our sisters, our aunties, our uncle, our grandmothers, and our grandfathers. Because if we are going to be talking about a lens, in order for us to understand our epidemiological space, we also cannot leave out the communities. And that's why we have to listen to what is this heartbeat. We have seen it in our health promoting messages during COVID-19, where our populations have said, you have said to us, clean your hands, do this, do this, do this, but we don't understand, and they have not adhered. We have seen it in the terminology that we use when we talk about vaccine hesitancy. Is it really true that our population are vaccine hesitant? Or have we not given them good enough knowledge? We have seen it when we as scientists, because we've been thrown into the public eye, where we are debating our epidemiology, our p-values, our confidence intervals, and our likelihood ratios within the public, and the public are saying, wait a minute, we don't understand this. And so where should those debates happen? Are they really supposed to be happening so openly in the public eye? And if you are saying to me that indeed they are, is it correct for us to be having those kinds of debates? Or where is the safe space for these debates to happen? Is it maybe the platform of AfEA where we as scientists can sit, debate our epidemiology, our p-values, our confidence intervals, so that when we go out to the public, we have listened to their heartbeat, their voice, how they communicate, how they do things, and we will be able to have one voice where we speak to each other. And that way, our population, when we say vaccinate, they trust us and they believe in what we are saying. That is such a crucial thing, colleagues. We cannot ever leave our communities behind, because in all our innovative spaces and in all our spaces where we want innovation, there is no doubt that if we are not listening, we cannot have a sustainable agenda. So as much as we are looking at a lens, that lens has got to be very much rooted in the sustainable agenda. And we have to understand what this epistemic noise is. How are we hearing? How are we listening? Because lensing is very much seeing, but also how are we listening to our populations and their desires and their needs. And I think it is important to reposture and to resituate the debates for the scientists with the debates for the academy, the debates for the general public. It is so important to say, what are we saying before we even decide on the kind of lens that we want? And so that will then demand for us, before we can talk about epidemiology through a COVID-19 lens, it means then we have to think differently. It means then we have to think collaboratively. It means then we have to think change. And when it demands us to return home to what we really know and what makes us truly Africans. And we need to be unapologetic, because when all is said and done, we have seen that the huge investments that have been made into the African health system, they have been slow and the gains have been slow. And the adoption of the global and African health agenda has not seen the translated gains to the Ogogo Mahlangu in Gala village, to to Ogogo Hufwet, who is in Cote d'Ivoire, and every single one of our grandmothers, grandfathers, and all those people and the masses. So we know the lags. We know the lags, and we cannot run away from those particular lags. And so what now? And so that then means that before we talk about lens, let's understand ourselves and our role. And we need to go back to seeking answers that will answer the question, who are we as a collective? And so it's through this collectivism, which is actually natural. This is the way we do things as Africans, an understanding of who we are, what we can do, our tangible innovations for our people, and ensuring that their voice is at the center stage, because we need to be, in order for us to have these innovative designs, the solutions, and the various lenses that we will hear this afternoon. And in conclusion, I want to stop with the words of Jim Adesina, who talked about, while it's important as a first step to rail against colonial epistemology and coloniality, the important work to be done is the actual practice of decolonizing knowledge. And so we talk to our public in the lens of a scientist, in the lens of what we understand in our textbooks and in our various debates. And we need to start in that lensing. The epidemiology that our population has to understand has to be in their language, has to be in the voice that they call themselves. It will require us to be opening, be familiar, be embracing, and to be quite engaging with the diversity of the African archives. And I do want to say that there is value, as Jim Adesina says, in the ontological, the epistemological, and the social political lens, because we can't run away from that. And so I really want to stop there. And my last words are really going to say that if we're going to look at epidemiology through a COVID-19 lens, let's not run away from demanding that we are called by the name that we want to call ourselves, but we cannot run away from our responsibility in terms of hearing, in terms of listening, and ensuring that each and every single person is not left behind in this beautiful continent. I thank you so much.
Very much for setting the tone. We will now go on to our second speaker, Professor Osibogun. For the audience, if you have questions, you can put it in the chat. And after all the presentations, we are going to have a panel discussion, and we can take on any of those questions. Thank you.
Okay. Good morning. The president of the IEA, the president-elect, and the organizers of this conference, I thank you for inviting me to make this presentation. I will also like to thank Professor Flavia Senkubuge for properly placing the context in which epidemiology has to be applied in Africa, by providing the philosophical and the ideological framework within which epidemiology has to be applied in Africa. What I intend to do this morning is not something that is going to be highly technical, but essentially to show how we can be applying epidemiological principles and methods in Africa to achieve results. I'll start by reminding us of the definition. Of course, that is, this will be the outline of my presentation. I hope we are seeing my slides.
Yes, sir.
All right, thank you. All right, so I'll just briefly look at the methods and tools, though within 15 minutes, one can't really go into town with many of the, but I think there'll be enough for us to ruminate over, and then look at common applications, and then, of course, look at what we've been able to use epidemiology to achieve in Lagos State. Epidemiology, as we recollect, is about the distribution, determinants, and deterrence of disease and health-related conditions and occurrences in defined population. Of course, if we know the determinants and we know the deterrence, we can use that information to control epidemics and to control disease. Therefore, epidemiology is very central to public health. Its methods help in providing the evidence for disease causation, transmission, diagnosis, prevention, and treatment. And of course, its methods include observational and interventional methods. Of course, we do know that interventional methods provide weightier evidence, but the challenge in developing countries will be not to wait until you have enough funds to conduct interventional studies, because clinical trials are extremely expensive, although they provide more direct evidence. But as you will see during my presentation, even observational studies, we were able to use them during this particular pandemic to achieve a lot of results, and you will see that shortly. The other point that I want to remind us of is that, of course, without race, you cannot make any comparisons. So the tools of epidemiology are very important, race and ratios, because they help us to make the comparisons and then to enable us interpret our results properly and come to some inferences or conclusions. So if you have a disease X, of course, you're searching for the causative agent, so you look everywhere in the body fluids, in the orifices, and so on. Fortunately, now we have molecular technologies, including sequencing capabilities, so we can now move rapidly to identify agents. If you can sequence an agent, you'll be able to have as much information as you need, faster than you could have done with earlier technologies of microscopy, serology, and biochemical markers. All these still add up. They still help us in identifying the agents of disease, because we may be able, if we cannot identify the agent itself directly, we may be able to identify the products of the agent, or we may be able to identify reactions to the reagents. By comparing rates of occurrence in groups, we can establish associations. And then, of course, we can subject established associations to test of significance to rule out the rule of chance. Of course, in our studies in general, we can be misled by three main factors: the rule of chance, confounding factors, and then, of course, bias. So designs of studies can reduce or eliminate bias and confounding. By designing the study appropriately, we can remove confounding factors, or in our analysis, we can also correct for confounding factors by the manner of analysis. Okay, so I just provided this table to show us how we arrive at rates and how we use rates to make comparisons, because rates enable us to know the likelihood of risk or the level of risk in different proportions. And by comparing the rates in the different groups, we can then say that one group is more likely, or one agent is more likely, or one exposure is more likely, particularly in the investigation of foodborne diseases. We talk about attack rates. And then, of course, for different food items, the attack rates are not usually zero, but then you will see that the figures are different for different food items. So the food items that has the largest rates, of course, will be the suspect food item. So rates are very critical for us to be able to make comparisons in our investigations. So the organism with the largest source will be the most likely agent responsible for the illness. In other words, if you take nasopharyngeal swab, for instance, you will find several organisms there. So it won't just be the SARS-CoV-2 virus that will be there, but you find out that the organism that you find consistently in many infected patients will be the most likely organism, because its rate of occurrence will be higher than other organisms that are not responsible for COVID. So how have we applied epidemiology in Lagos State? And start from item number 2, actually, because that was our first paper from Lagos State, which was published in May of 2020. You remember the first patient that got into Nigeria on February 27, and he spent almost 2 months on admission because that was the limit of our knowledge as at that time. We kept on, everybody was scared, to put it that way. So we kept on repeating the PCR, and the PCR kept on returning positive and so on. So subsequent patients after him stayed on the average about a month or more. And for each patient, the Lagos State government was spending like 100,000 naira per day to keep these patients in the ward, And then, of course, we kept on repeating PCR tests. PCR tests in Lagos was costing about 50,000 naira. So you kept on repeating that for every patient. And then, of course, we were having challenges because we were responding to the panic outside, everybody wanting to be tested. And we had only maybe 1.5 initially, then 2 laboratories testing in Lagos. As at that time, I can tell you now that in Nigeria, you have over 100 public and private laboratories testing. But as at February, March 2020, so we were limited. So the results were taking 3-5 days, at times a week, to come out. And that was extending the stay of the patients. And we are saying that to discharge a patient, there must be 2 consecutive negative PCRs. So that was taking, the patients were kept in the ward for a very long time. So this first paper, then tried to look at how long it took the patients to convert to seroconvert, or to convert to negative PCR, not sero, to convert to negative CR. And this paper, even though we looked at a very small number, the first 32 patients in Nigeria, we then found out that the median duration of hospitalization was 12 days, which meant that they converted PR negative within 12 days. And then if you notice that it was taking 3 to 5 days for the lab results to come out, what it means is that the sample must have been taken around day 9 or day 10. So we then use this finding to inform policy in Lagos State. And the policy then became that we didn't need to keep any patients for more than 10 days on admission. And in practical terms, this was a lot of savings, because if you are keeping patients for a whole month, 30 days, and now you have to keep them for only 10 days, you are saving 20 days of hospitalization. And each day was costing 100,000 naira times 20 days. That was already ₦1 million per patient. So you can use epidemiology to inform policy. That was what that first paper, I put it as number 2 here. That was the first paper that came out. The second one that I want to draw attention to is the one I've listed as number 1, predictive ability of symptomatology. So everybody was worried, and every fever, was almost tagged COVID. And then, of course, the policymakers and the government officials who have had to divert all other funds to respond to COVID were worried about the cost of the investigations. So they're saying, okay, if they have cough and they have fever and they have general weakness, why don't we just, assume that they were COVID, so that we reduce the cost on testing? So we said, no, well, we will have to investigate that to be sure that there's evidence for that decision. And that informed this study to look at the predictive ability of symptomatology. And as you can see, our main findings suggested that fever was only 28.9% predictive and cough was only 21.7%. So we said, no, the symptoms are not predictive, because there are other conditions in our environment that also cause fever, that cause cough, that cause general body weakness. So we discarded the idea of relying on symptoms to make diagnosis. If we had relied on symptoms to make diagnosis, we would have wrongly classified, patients. Those who did not have COVID will have been classified as COVID. And there were a lot of COVID patients who are asymptomatic. In fact, as much as I think 80% were asymptomatic. So if you are going to rely on symptoms, you will miss many of them, and then the transmission will continue in the community. So we then recommended that the PCR should remain the tool for diagnosing and for follow-up for contacts. So those who are close contacts, we were not going to be waiting for symptoms. We will use the PCR to look at them. The third use that we made of epidemiological methods was to look at presenting symptoms and predictors of poor outcomes among 2,000 patients that we had in Lagos as at July 2020 or thereabout. So we looked at the symptoms, and we looked at what predicted poor outcomes in these patients. And then we discovered that dyspnea, or difficulty with breathing, was the single most important predictor of mortality in COVID-19 patients. And of course, if they were short of oxygen and they were dying, the logical thing was, as early as possible, give them oxygen. And so we started an oxygen therapy policy in Lagos State. So whenever they showed the slightest sign of difficulty in breathing, we started them on the oxygen. And we noticed, and we will still look at the data for that, but we noticed that the need for ICU or the need for more aggressive treatment reduced with oxygenation. And then, of course, the pulse oximeters was also freely used now, and we were monitoring the oxygenation level. And once we started them on oxygen early, we saw that their chances of survival was increased. So that was the third use that we made, or we applied epidemiological methods to. And then, of course, the fourth use that we applied it to, or we made use of it, is to then look at comorbidities and look at COVID-19 and comorbidities and see the outcomes. Of course, those who had comorbidities had the higher chances of dying. So cancer had an odds ratio of 14.12, renal disease 12.53, diabetes and hypertension. They were the leading predictors of mortality in COVID-19. And what did that do? That informed our decisions in clinical management. So whenever we saw a patient who was SARS-CoV-2 positive and had any of these predictors, we intensified the treatment for that particular patient. We paid more attention to that patient so that the patient could survive. We treated, provided more supportive treatment and more definitive treatment where there are definitive treatments for the patient's conditions. So you can see that even without going into the realms of interventional studies, we were able to use observational methods, to get evidence that informed policy in Lagos State. But we also did a few interventional studies. We were looking at convalescent plasma in the treatment of COVID patients, and we were trying to see whether it influenced mortality. Even though that study, we moved with it to some point and we didn't conclude it because the results were not dramatic and the resources that were going into it were not cheap. So, but what eventually happened is that we now partnered with other researchers in different parts of the world, and all the studies were pooled into one systematic review of convalescent plasma treatment and mortality in COVID-19, looking at mortality rates in both treatments and control groups. And we found that this systematic review found out that the outcomes were similar, 23% and 24% in control groups, 23% in the treatment groups, those who received convalescent plasma, and 24% in those who did not receive convalescent plasma. This, the results were published recently in the PMC Infectious Diseases. Of course, this has implications for the use of resources. Please note that it might not be that convalescent plasma is totally useless. It might be that the concentration of antibodies in the convalescent plasma as we are using it is not high enough to make a difference. So this might call for further studies because we are using convalescent plasma. So dosing was not really determined, and there may be a need for further studies. But definitely the systemic review that we had showed that it didn't make any difference. We also looked at, during the outbreak, a lot of rapid diagnostic kits were brought into the country, everybody coming in with all kinds of 99% sensitivity, 99% specificity. Our main concern in Lagos State was we wanted clinical validity, not in vitro validity. So we advised the Lagos State government not to make any purchase of any RDT kit unless and until the RDT kit had been subjected to clinical validation in Lagos State. In other words, if you have either an antibody or an antigen RDT, we want to see how it compared with patients who have been tested with RT-PCR. If your validity is sufficiently high, then we'll recommend to the state government. Unfortunately, we didn't find any kits in year 2020 that was of responsible level of validity that we will have recommended to the state government. Of course, it was a novel disease, so it's understandable that throughout 2020, laboratories and commercial enterprises were all struggling to fully understand the virus. I'm sure that by 2021, we may now have rapid diagnostic kits that may be dependable. We've not tested them, so I will not pass any comment, but I suspect that a few antigenic-based kits have now been recommended for use by the NCDC in Nigeria. So we also did a few clinical trials, which are the, which could provide more definite evidence of relationships, causal relationships. But sorry, I don't know whether I jumped I think I jumped, yeah. So we are looking at mouthwash because the mouthwash is suspected to perhaps cause a destruction of the virus. Unfortunately, our findings were that the mouthwashes were not so useful in preventing, particularly in reducing hospitalization. I think our study was in hospitalized patients, so in reducing hospitalization. I guess the mouthwash, if we probe further, may be useful in preventing, theoretically, because it may destroy the virus as soon as it lands. But I suspect that it didn't make any difference in the hospitalized patients, because once the virus has been able to enter the human cells, the mouthwash will no longer be so useful. Once the virus has been able to bind itself and penetrate human cells, the mouthwash will not be useful. And that exactly was what we found in our clinical trial with the mouthwash. The other one that we also tried to do was the ivermectin study. Again, that had not been concluded, but unfortunately, while the study was going on, there was so much information on the social media about its usefulness, and every patient that you now saw in town was already on ivermectin. So it made the continuation of the study impossible, because now we could not have any control, because the patients themselves would have bought ivermectin from a pharmacy and were already on ivermectin. So it was now difficult to have a treatment and a control group, because everybody was already self-treating with ivermectin. So epidemiology, as you can see from these applications that I've given, are so crucial to public health and to the control of epidemics. Dr. Debi asked me to talk a little bit about training for epidemiology. I guess training for epidemiology has to be emphasized if you are going to have people who are competent to apply these methods, to be able to design studies, to be able to manage the data, to ensure data integrity, and to be able to analyze the data. In 1993-94, we did develop an epidemiology training program for the district health team for the African region. Well, I don't know whether that is still continuing. I know that we now have AfEA, we now have all kinds of programs, but we must have programs at different levels, and the one we designed in 1994 was a 6-week program consisting of both didactic and practical exposures that will enable the district health teams, community health officers and people at that level to be able to apply basic epidemiological principles to collect data, analyze the data, interpret the data for decision making at their own level. Of course, training will also be required at higher levels, for people who will have their masters in epidemiology or masters in public health, and for people who have PhDs in epidemiology and in public health. I think with those words, I would like to thank you once again for listening, and thank you again for inviting me. Over.
Thank you very much, Prof. Our third speaker regrettably had to leave because he has another meeting. In place of his presentation, I would want to invite any of our panelists who want to share their experiences, of what they did during the COVID-19 pandemic, which is ongoing in their different countries, before we go into discussions.
I suspect that my presentation has largely been sharing of some of the things that we did.
Yes, sir.
I just want to mention that in the 12 to 16 months of the epidemic in Lagos, the Lagos state government prioritized research, and you can see that it has paid them off. I've given, for example, I think in the 12 months or so, we've had about maybe something around 16 to 20 publications. I said 16 to 20 because about 4 or 5 are still being peer reviewed. You know, so and research has not been money wasted because you can look at the savings that was made by the state government just by reducing the length of hospitalization from like 30 days to like 10 to 12 days. It was a huge sum of savings. Savings also in terms of not wasting money on rapid diagnostic kits of doubtful validity, doubtful clinical validity. You recall that even in the United States, a rapid diagnostic kit threw the White House into some kind of turmoil because it gave them false results. So it was very important for us to have insisted that any kit that was going to be used in Lagos State had to be clinically validated to be sure that, you know, whenever it says that the virus was present or has been present, if in the case of antibody test, you know, the virus was present or had been present, you know. So, and then of course, we looked at the mouthwash, and we also looked at some local labs. We were looking at black seed oil. I think that is still ongoing. But when we started, then I think we started during the second wave. Then the wave went down, then there were no subjects to be recruited. So it gave us some, but I will speak to the principal investigator to find out where we are. So there's no doubt in my mind that without epidemiology, you cannot practice public health because it provides you the tools and it provides you the evidence for decision making. Thank you.
Thank you, Prof. Now, one of the major observations that has been made since the—
Sorry, Doctor, can I just quickly put in one thing?
Okay, sir.
Just to commend the National Primary Healthcare Development Agency because the pandemic is still going on and they've brought in vaccines. They did not just bring in the vaccines, we've been following up with the vaccinees. So we followed up the vaccinees now for over 3 months, 84 days, I think that's 3 months, yes, 12 weeks, looking for adverse effects following immunization, not passively, actively looking for. So it meant that every vaccinee had been calling in. We gave them data and research card so that they could call in, and we were calling them every week. So we have evidence, enough data to show that the vaccines are safe. We also did a smaller study collecting blood from a smaller sample size. The bigger sample size was 1,284 vaccinees. The smaller sample size was just about 125. We looked at hematological parameters also for safety, particularly because in AstraZeneca, there were stories about clotting and so on. So we looked for platelet counts, so I don't know whether I should present the results now, but we have all the data. And the National Primary Healthcare Development Agency has all the data and is confident in rolling out the vaccines that it is rolling. So it's not just rolling out the vaccines, it's also obtaining the evidence, to show that it is monitoring what it is doing and that the vaccine is safe. And then we also monitored for immunogenic responses to see whether the vaccines are eliciting cellular and humoral responses. And we have data on CD4 and CD4 and CD8 counts, as well as data on neutralizing antibodies. So I just wanted to point that out, that we are still using epidemiological tools and methods to follow up, to even see how we are responding to the pandemic. Thank you.
Thank you, sir. There's a question here from Dr. Oladejo from the Nigerian CDC. He said, thank you, sir, for this presentation. Can you throw more light on the RDT studies and how its findings were used for informed decision? I think Prof has addressed that concern when you mentioned that the findings were used to advise the government on whether to move on to use the kits or not. I guess Prof has addressed that. Then there is another question from Dr. Oladejo to Flavia that thank you, Prof, for the presentation. Can you explain how we can benefit from this pre-colonial era in terms of sociology, political factors mentioned in your presentation?
Do you want me to go first? Because we have a question for Prof as well.
Prof's question had already been addressed in the second part of the commentary that he made.
Yeah, so I think the answer is twofold. I want to answer the question which is in the chat as well about kind of the practical steps of how we decolonize, global health. And the first one is really, first of all, is to ensure equal partnerships. Particularly, I think I will limit myself to the work that this organization does, and that is in research. I think for so long, what we have become as, as African institutions is data collectors. And so what happens is that after collecting that data, it's then shipped elsewhere, and then we get a kind of a little acknowledgement somewhere, and we don't have good authorship in that. And I think the first one, which is tangible, is how we structure those agreements when we come up with various research that comes up. Because the truth of the matter is that is our data. And that data always, in as much, I think we have to adopt some of the business models. If you look at any investor that comes from outside, it is such that you have to have a local partner, whether it's 51% of that particular business. And I think as academies, whether we are institutions of higher learning like university or organizations like AfEA, if we are going to be entering into a partnership, we've got to write those laws into place and say that you have to have a true partnership. That is the first thing. The second thing is around funding. In terms of the funding models, we need to fund the African agenda. And so if we don't know, that's why I kept on talking about our voice. What is our African research agenda? What is our African epidemiology agenda? So if we're talking about socialism and things like that, it all ties into that voice thing, which is about what is our research agenda. So somebody can't come from elsewhere and say, I think this is what you are suffering from, and this. So we can't drive an agenda of somebody else. And so we have to have a proper research agenda. And then Professor Akin was talking so beautifully about the work that they have done. We need to fund these things of the good stories that have come up. It can't be written by somebody else, because if we don't, and we have to be intentional about these things. So how are we, supporting people like Professor Akin to write up the story? Because on top of the work that he has presented today, there are many challenges that he hasn't presented for himself as a leader. How was he handling the work-life balance, his family, all those kinds of things during this time of a crisis stage? How was he handling it in terms of information dissemination? Remember, for us, not everybody watches TV. The grandmother in the rural areas. So what were those debates behind the table? Because a lot of people can learn from that in terms of how Africans are health promoting and health communicating. So the writing up of the stories. And I think the last one that I want to say, Dr. Kahn, is around how we are bringing in, if we are going to be talking about the pre-colonial time, remember that in the pre-colonial time, each and every single person actually had a space. Nowadays, it is us ourselves who are in that space of creating researchers and the evidence. Where are the young people? Have we created a space? So if I am in my department, who are the next generation leaders that I'm pulling and bringing along and ensuring that even if they are not there yet in terms of research methodology and things, they can just come in and listen in. even if it's a meeting like this, and learn from Professor Akin, learn from Professor Adebayi, learn from. So a lot of the people, for instance, who are on this panel and on this webinar today, we come from the trenches while we were residents and things like that. And now we sit in these spaces, and we brought a number of our young people along, because we then create that pipeline. And I'll tell you why that is important, because of that texturedness and those discussions. You cannot learn them from a textbook. You have to listen. Oh, is this how Dr. Kahn responded when they were invisibilizing him, when they were negating the work that he has been doing, when they were shushing away his Lancet publication? It is so important. So the question that one of the colleagues asked in the Lancet review previously, who are we decolonizing for? And who are these people, and what are we decolonizing for, is something very important. So for me, if we create that critical mass of people who are coming in, if we are creating our own narrative unapologetically, because if you come to my house, you can't tell me, move your chair there. I said, this is where you sit. You have to sit there. And if I offer you, I'll ask you, what coffee would you like? I'll offer you what I have. And so I think it's so important for us to shape that. And I do have a number of colleagues that I don't work alone, like Professor Ozochukwu, who may want to add, because we work together on the space of decoloniality. Thank you so much.
Thank you very much, Ma. Now, Prof. Osibogun, you mentioned that Lagos State government provided a lot of funding for research. Now, that is very, very impressive. How were we able to convince them? Was it the urgency of the crisis, and how can that be sustained? Because that is another issue again, because long-term, we need to have funding to support, the aggressive nature in which you approach the problem.
Thank you very much, Dr. Kahn. You remember that in 2014, Lagos had an experience with Ebola virus disease.
Yes, sir.
And we learned from that, it caught us almost unawares, even though we got up on our feet and were able to respond to it. It took us about 3 days to make a presumptive diagnosis of Ebola virus disease in 2014. And even at that, we were not certain, we were not specific that it was Ebola virus. We were only able to say filoviridae group of viruses. So it took another 2 extra days for the sample to be sent to, I think, Redeemer's University, the laboratory, and then another laboratory in Senegal. So, but we learned from that. So in 2016, we had a conference to review what happened in 2014. I think it was, yes, in 2015 or 16, we had that conference, and some international researchers also attended that conference in Lagos. And then we started discussing with possible sponsors. And then the Canadian government supported Lagos State government with a laboratory, BSL 3 laboratory. So since 2016, we had been trying to develop that system. I think the laboratory was completed in 2018 or January 2019. So the new governor that came in met that laboratory, and we had to brief him. So, and he bought the idea of getting prepared for the next epidemic. So he started training the personnel and so on. So when news came out that there was this virus coming out of Wuhan, before we had the first patient in Lagos, he accepted set up an incident command system, and he is the incident commander. The commissioner for health is the deputy incident commander, and then we have an incident manager. So, and we launched that incident command system, I think, by middle of February 2020. And then the first case came in on 27th of February 2020. So, although he went off to Ogun State, because we were already in Lagos State, we brought him back to Lagos State and then admitted him, and the laboratory was there. So the current governor is convinced about investing in prevention. I think that's the luck that we've had. So political leadership is very key, because policy determines funding. And if the political leadership is not bought into the concept, they will not have a policy that will enable them to put money into it. Well, I did say it's funding, but at least it's doing something. We are not having all the funds that we need, but at least we praise him for even, being so focused and forward-looking. So we set up different pillars in the incident command system. So the research pillar is one of the 5 or 6 pillars that we have. And he allocates budgets to all the pillars. Of course, case management got a lot of money, and laboratory investigations, PCR testing in particular, got a lot of money. But the critical thing that I want us to bear in mind is political leadership is very, very important into directing the appropriate funding, allocation of funds for research. Thank you.
Thank you, sir. There is a comment from an anonymous attendee who said, in terms of adequate education, some students have successfully been trained in epidemiology at MSc PhD level. How is AfEA planning to take advantage of the human resource instead of brain drain to develop countries? Like me, I would love to give back to African public health in terms of research. Well, I think this is a comment that Professor Adibi and our team will look at. I don't think we might have time to, make a conversation around that. Then also there's another comment here. Thanks from Dr. Oreolua. Thanks so much for the opportunity to be here at the webinar. I want to come from Professor Flavia's angle of looking inwards to solve our problems and challenges facing our health system, especially during this pandemic era. So he went on to ask the question, what can we do in developing our own African testing kits, vaccine production, and African ways of treating most challenging health issues? Thank you very much, sir. So, well,
I want to,
Flavia,
would you like me to answer that?
Yes, so it's like, how do we depend on ourselves to, develop our own diagnostic capacity and also therapeutic?
Yeah. So I think I want to answer that. I think not just only the diagnostics, but in a broader sense, how do we ensure that we have upscaling and incubating, African technology? And the first thing that happens is, and I use this word invisibilization, that if technology that comes from Africa is developed and we say, oh my goodness, there's a testing kit, the first thing that the global world will say is, oh my goodness, that probably does not work. That's the first thing. And we cannot run away from that. We like to use these, fancy words of saying, let's partner, but that's the reality. And so in essence, I think the first thing is one, collaboration. While we are where we are, we need to speak the truth. And that truth is that any innovation from Africa will be seen as less than or inferior or not effective. And so we need to, one, collaborate with partners. Who are these partners? The partners are in Africa. If you look, for instance, at our university, at the University of Pretoria, we have what we call the Innovation Hub. That Innovation Hub works together with a number of industry players. And we have a campus that we call Future Africa. That Future Africa is open to each and every single African scholar across the continent. And you can come and stay at our university and do those innovations. We incubate people, we protect, we create the intellectual property while you are developing it, so that when you scale that product to market, it is still yours and it is well recognized. Because what happens, Dr. Kahn, is that sometimes if we realize, oh my goodness, this really works, somebody else will white label it and then sell it as their own. That's the reality. And so the first one is that we have to use African money to invest in these innovations. That's the first thing. And we do have the money. And that money is in institutions like in our institutions at the university. So we have to flatten these silos of various universities working differently. For instance, at our School of Public Health, we work very closely with the University of Ibadan. We work, as I was saying, with colleagues like Professor BSc Ozochukwu, who is our external examiner. In that space, we are able to create an African agenda now working on decoloniality. But when it comes to innovation, we are certainly right now, maybe hot off the press, I can say, we are definitely creating an innovation hub for health innovations. And that's the place I think where we should locate. So we need to create these safe spaces where we can create whatever we want. And those creations are not only to solve African problems. A lot of those solutions will be created in Africa, but will certainly be able to solve a number of global programs. So in short, one, let us work together in a collaborative sense. Let us help, because a number of these innovators are young people. Let us fund them in spaces like our innovation hub. And three, we want to make sure that we have a business case, and we have to be aggressive about it. We cannot say, oh, you know, we're going to talk about it, you know, we're still developing this. No, we need to know how to hide it, how to really do the IPs and all those various things to protect that innovation. And then when it comes up, let's scale it up, use it, you know, do the research, have a look, is it working, is it not working, and then scale it up to market. Partnering up with other global companies. It can't be other global companies coming to us because they will buy us out. But if we do it the other way around, and we have, it's just to the interest of time, we have a number of innovations at our university that we have done like that, and they're used in the global space in terms of solving. The one of them is, for instance, the mobile hearing earpiece that was done by our colleagues in the speech therapy department. So those things are there, the innovations are there, and I think we need to fund our young people and incubate them. So I want to invite anybody who wants to come and spend time at our university to do that. Thank you.
There's one other question that was directed to both speakers from Dr. Akimayowa Lawal. How valuable are social epidemiologists in AfEA's agenda and in the decolonization of African health system? The question is to you, Flavia, and to also Professor Osibogun.
Well, we don't have
second part, because the first part will be to the AfEA leadership, which I don't think this webinar is for that. But the person is more or less asking what is the contribution a social epidemiologist can make in the decolonization agenda?
Yeah, so we need them. That's the short answer of that. We need them, and that is not only just social epidemiologists, but all epidemiologists have to be conscientized in understanding the space and getting their voice as Africans in terms of the decoloniality and that language. And so one of the things that we do need to do is in our schools of public health, in our residency programs, we need to make sure that we are teaching these things, and this, because decoloniality is not a thing. It is a way of, it's a mentality, it's a way of being that has to be mainstreamed in each and every single one of our practices, whether it's clinical practice, epidemiological practice, public health practice, global health practice, because we haven't given space to our young researchers to create and find their voice as true Africans. And because this conference is about the lens. And so our lens has got to be that. And so we use this word, and a lot of people are afraid of the decoloniality, but really what we are saying is that what is our voice in terms of an African lens? So the role of the social epidemiologist then becomes extremely important, because I like to say social epidemiologist is the one who creates the social consciousness and the artisticness of the numbers, you know. And so the epidemiology is usually raw, is just the numbers and what is going on. But these social epidemiologists are able to interpret I almost want to say the heartbeat of the numbers. So we certainly need them. And I think that it's not just only social epidemiologists, but I think epidemiologists across need to have this sensitization by introducing the curriculum, and also being part of webinars like this, where they've heard, you know, kind of the language that we want to use, and they'll be able to apply it.
The person asking the question, I think he also directed the question to Professor Osibogun, and here he is saying, what role and contribution did social epidemiology make in all the studies that you have conducted in Lagos State, sir?
Well, I totally agree with Flavia, you know, but another angle to it is to look at the social determinants of health. And if you are looking at the social determinants of health, We do know that behavior and anthropology are also very important and I'll give you a very specific example. During the Ebola virus disease outbreak in 2014, we recall that they have the culture of burying, dead bodies. And of course, that practice was also contributing to the transmission of the virus. So definitely you need people to also be able to study or to have inputs into the study of human behavior as it affects disease outcomes and disease outbreaks. So they also come in with methodologies that are, should I say, that are social in nature. For instance, we talk about qualitative methods, which we've now incorporated into public health. So those qualitative methods are not useless. They at times provide further insight into what the numbers provide. And I think Flavia alluded to that they provide the art of the numbers. So the qualitative methods will then give us the opportunity to have an in-depth understanding of what the numbers are showing or why they are not showing that. We conducted one study in 2 villages. The pipe-borne water was provided just at the border of the 2 communities. And the people in the other community would never take the water, so diarrhea was still dealing with them. Our assumption was that by providing the pipe-borne water, you are going to solve the diarrhea problem in the 2 communities. And by putting the water source, at the boundary. But there were age-long traditions held by the other community that they must never eat the food of the people of that other side, and they must never drink their water. So they never use the water. So we didn't understand that. We were just doing quantitative studies. They were asking if there's pipe-borne water, would you use it? They said yes. But when you actually provided it, they never used it. So social epidemiology is very important. Thank you.
Thank you very much, sir. Now, we're almost coming to the end of this very important program. We want to thank the speakers for making our time to attend this very important meeting and to share their experiences across the continent. One issue that I would have loved them to talk about is in a reflective mode, looking backwards with the wisdom that we've gained over the last 2 years that COVID-19 has been with us. Africa was, the fear initially was that Africa was going to be ravaged, but we proved the world that Africa was not going to be the main battleground of COVID-19. Shockingly, in the first 6 months, the developed countries were hit most, and our health system, is at bending knees, but we were able to overcome all these challenges. What do you think the rest of the world can learn from Africa? Even though there are theories around our resilience, maybe our immunity was responsible for the lower cases, or maybe the underreporting, but generally Africa did well during the COVID-19. What can we learn? What can the rest of the world learn from Africa? On a closing note, thank you.
Well, before Flavia unmutes herself, I'll just quickly say that we continue to learn. I'm not sure that we know everything about this pandemic as at now, but one thing is certain, African countries responded early. I don't know whether we responded sufficiently, but as at the time we started monitoring our ports of entry, several European countries were not doing that. They had the assumption that the virus was just going to be like the common flu. Then, of course, it is also suspected that other pre-existing infections might have conferred some level of protection. We need to interrogate that. We need to investigate further. One of the infections that has been claimed is malaria. But the question that I have asked is that malaria is also in India, and malaria is also in Brazil. next to the United States, Brazil has been badly hit. India too, you know, although it had initial reprieve, but India has been badly hit. So we need to investigate further so that we can learn some things that can help us in future epidemics. Thank you.
Quick comment, Flavia, what can we teach the rest of the world?
Yeah, I mean, I have so much to say, but I will limit myself to 4 things. I think one, that we are resilient. I think there's no doubt that, you know, in South Africa, we have so many mantras for the resilience of Africans. And the first thing I want to say is that we are resilient. That's the first thing the world can learn. The second thing is that we have learned. We have learned from our community structures work. And so one of the things, the first webinar that I attended, somebody said to me, oh, you know, they were asking a question and said, oh, how come nothing is happening in Africa? I said, you must understand, we've been through it all, Ebola, HIV, and all of that. And we have built very good community structures. And so if a message comes out, we know how to disseminate it from the president's office right down to the remotest rural area, because we have ward committees, and it's interesting that the rest of the globe doesn't have that. We have village committees and so on, community health workers. And yes, can we improve them? We can, but they are there. And indeed, they did work through COVID-19. The third one is that we've got amazing specialists and colleagues in the health fraternity. One of them, Professor Abdool, Karim, he held Africa. He talked about, you know, the case of Africa using the lens of South Africa. We've got Professor Akin. We've got so many of them who are on this call. And I was so delighted, Dr. Kahn, that for the first time, our scientists were getting the due reward and recognition. Why? Because we had to do webinars, and from webinars, international partners had to attend. And so it's showcased that we've got some of the best scientists who are unapologetic and who are able and can stand in head and shoulders. And I was very proud of African governments for using those scientists. I don't think we give them enough credit. When COVID-19 hit, the first thing African governments did was not to ship scientists from all over the globe. They said, who do we have in our country? And then all of a sudden, because our scientists were exposed to the media, and even our population was able to say, whoa, we have this person, and they heard the voice of our scientists. And the other thing which I'm so excited about, and I must say this, is the women agenda. In terms of many of the responses in Africa were driven by women, led by women, and supported by women scientists. And certainly I think, yes, we can do more, but I was terribly excited to see many African countries bring in their women to lead ministerial committees, and showcasing to our partners globally who didn't have women on their panels, that in fact African women scientists exist and they can lead. Thank you so much.
Thank you. And I think most importantly, Dr. Tedros, an African, is leading the global effort. So thank you very much. And I hand us to Dr. Maki. Thank you, sir. Dr. Maki, are you on?
Yes, I'm here.
Okay. So I think
Hello, can you hear me?
Yes.
Yeah. Thank you so much, everyone, for everything for the attendance today. Now we want to go to the regional counselor currently, Professor Aman Kweshu, who will give the votes of thanks and the closing remarks. And thereafter will be a close of the webinar, and we will be moving towards the AGM for those who are members of AfEA. Over to you, Armand.
Okay, Maki, thank you. The president of IEA, Professor Chandra, and the president-elect of IEA, Dr. Akin, all the distinguished guests or panelists and the guests. I'm really pleased to be here with you, and it's a single pleasure for me to be part of this meeting. That's the first AGM of the AfEA that is holding virtually. From Tinapa in 2012 to Maputo 2019, and where we are today, we have really made a move. Those some will not estimate, some will estimate that it's not enough, but my personal view is that we are moving, but we need to move further and faster than we are doing now. I will say the panelists really took all I had to say, like Flavia, particularly on decolonizing our health system. She explained lengthily. I appreciated, and I even sent some private messages to her. I discovered also Professor Akin, who showed an example of local scientists can make a decision and be implemented in the country. It's not the first time in Lagos, particularly during the Ebola. I was very pleased the way Nigeria, still Lagos State, handled a case of Ebola that came into the country. So recalling all this makes that they are already, as Flavia said in her last word, that there are local people who can make it. And I think we should believe that. Raising funds locally, she also said it, yes, we should think of raising funds locally to make our personal agenda. Nobody will come as somebody will bring you funds to go to his agenda rather. So collaborating, thinking differently will really help to move forward. I was very pleased for this meeting, and I will give you for my thoughts. Thank you. Akin, over to you.
Thank you, Armand, for the wonderful and beautiful words. And then we're going to move to the close of the program, as we have said. Any last words from the president-elect of the IEA, Akin Adiebi, before we final closure?
So thank you very much, Maki. I won't be saying a vote of thanks again, but I want to leave you the words of Professor BSc Uzochukwu, who highlighted the fact that we need to strengthen the South-South collaboration as well as research networks. And this is already going on. The Maputo Declaration was a landmark declaration for the AfEA. Flavia had actually talked about this. We need to begin to reimagine our health systems. We need to begin to rethink our epidemiology. And in moving forward, we need to learn how to collaborate with each other. Thank you for joining, and thank you for staying till the end. God bless you all.
Thank you, everyone. With that, that is the closure of the program. The recording will be available, and we hopefully will also be writing this up for publication in the IEA journal. So please have a good evening or day. And those who are members of AfEA, please log on to the meeting. Thank you for the annual general meeting. Bye. Have a good day.